Good morning, everyone. Welcome to the today's presentation. I'll discuss a particularly instructive and somewhat uncommon case of benign paroxysmal positional vertigo (BPPV) that came to our attention in the fourth week of July 2026. The patient is a 63-year-old lady with no significant past medical or surgical illnesses. She presented with a 3-day history of brief positionally triggered vertigo, specifically provoked when she lay supine or turned onto her left side. On examination, her gaze holding, smooth pursuit, saccades, and cerebellar function were entirely normal. The left Dix-Hallpike test evoked a classic slow crescendo-decrescendo left torsional downbeat nystagmus. The right Dix-Hallpike test, however, was initially negative. Only after repeated flexion and extension of the cervical spine in the right Dix-Hallpike position did a transient left torsional downbeat nystagmus appear. These findings raised the possibility of an apogeotropic variant of the right posterior semicircular canal BPPV, with the debris possibly lying in the non-ampullary arm of the canal near the crus commune. We carried out a reverse Semont maneuver. After the final 180-degree transition into the right lateral recumbent with face up, a brief upbeat right torsional nystagmus was observed. This confirmed that the debris had migrated from the non-ampullary portion of the periampullary region of the right posterior semicircular canal. Immediately afterwards, a right sideline test produced short-lasting geotropic horizontal nystagmus. The head yacht test was then demonstrated a geotropic nystagmus on both sides, which was horizontal stronger on rightward head yaw, indicating that the debris has switched canal into the long non-ampullary arm of the right horizontal semicircular canal. A Gufoni maneuver was performed for the right horizontal semicircular canalolithiasis. A day later, both the Dix-Hallpike test and the Hadyaw test were negative and the patient was completely asymptomatic. This case beautifully illustrates several points: the recognition of apogeotropic posterior canal BPPV, the value of repeated cervical movements to unmask the nystagmus, the real-time observation of the intracanalar migration, and subsequent canal switch into the horizontal canal, all successfully managed in a single session. In the next few minutes, we'll walk through the eye movement recordings and the rationale behind each maneuver and the practice lesson this case offers for everyday otoneurological practice. So, this is the title slide: Odyssey of Otoconial debris from non-ampullary arm of left posterior semicircular canal via periampullary migration to long posterior non-ampullary arm of left horizontal semicircular canal. So, as I noted that this patient had history of vertigo on lying recumbent to left and lying supine. So, after doing a clinical examination of the neurological neurooculomotor examination, we did the left Dix-Hallpike test, which is here, and as you can see that the head hanging left Dix-Hallpike position evokes after a very short latency a slow crescendo-decrescendo left torsional positional nystagmus. The upper corneal posts of both eyes are torsionally rotating to the patient's left, and because this is a semi-paroxysmal slow crescendo-decrescendo positional nystagmus, this is most probably arising from a otoconal debris in the non-ampullary arm of the right posterior semicircular canal, because the torsional component of the nystagmus in the apogeotropic forms of posterior semicircular canal BPPV is directed towards the non-involved side, which is left in this case. We did a right Dix-Hallpike test also. During the first head hanging position, there was hardly any nystagmus. So, as we had known that these can transform into the geotropic forms by repeated extension and flexion of the cervical spine. So, the same was being done here, as you can see. This is the Luigi's Califano's method of transforming the apogeotropic forms of posterior semicircular canal BPPV into the geotropic frame, and this usually occurs when the otoconial debris is in the periampullary location. So the learning thing from the Califano's 2025 publication is that the apogeotropic can also result from the periampullary located posterior semicircular canal lithiasis. So, however, we could see only a transient downbeat left torsional positional nystagmus, and both Dix-Hallpike tests therefore suggested a right-sided apogeotropic posterior semicircular canal BPPV. So, what did we do next? The reverse Semont maneuver was done. How the reverse Semont maneuver works is shown by this diagram. As we see, this is the position of otoconia in the extreme left non-ampullary arm near the cross commune. As the patient is taken to the nose down position to the non-involved side, the otoconia comes to the lowermost portion of the canal, dependent portion of the canal, and as the patient is again taken to the sideline position, that is position 3, it reaches the periampullary region. So the reverse Semont maneuver was undertaken because this is a patient whose torsional component was towards the left side. The nose down position was to the patient's left. With the short sitting, patient was put in left lateral recumbent with nose down, and then immediately through a 180-degree swing, she was taken to right lateral recumbent with nose up. And as you can see that after 1 to 2 beats of left torsional downbeat nystagmus, there occurs a transformation to right torsional upbeat positional nystagmus. But this needs to be confirmed by either a right Dix-Hallpike test or right side lying test. We prefer to do the right side lying test. Which is shown here, the right side lying test. The head is rotated or yawed to the patient's left, and patient was taken right lateral recumbent with nose up. And to our surprise, we see a geotropic horizontal positional nystagmus. So this patient has now transformed into the geotropic variant of the right horizontal semicircular canal BPPV. But we need to carry out a head yaw test also. We started the head yaw test right here only, and we can see a geotropic horizontal positional nystagmus during the left head yaw also. However, a head yaw test was repeated again to confirm the intensity of the nystagmus. So, how the otoconia migrated from the periampullary location of the right posterior semicircular canal to the long posterior non-ampullary arm of the right horizontal semicircular canal during the side lying test is a matter of interest. This is shown here. The position A is the initial sitting position with the head yawed 45 degrees to the patient's left. B is this right side lying position, and C is the back again sitting position with the head yawed 45 degrees to the patient's left. The lower panels, they show the orientation of the semicircular canals, and as you can see in the lower panels, right down on the right, the otoconal debris is here as the patient is in the position A above. As the patient is taken to the nose up position or the face up position, that is right side lying test, the otoconia moves towards the dependent portion of the canal, and as the patient is taken again to the sitting position with the head yawed 45 degrees to his non-involved left side, the otoconal debris, instead of going into the utricular macula, it reaches the long posterior arm of the right horizontal semicircular canal, and thus converting it into right horizontal semicircular canal lithiasis of its long posterior non-ampullary arm. So we confirmed it by the head yaw test, which is here. Sit to supine, we do not see any lying down nystagmus. This should always be observed for at least 30 seconds because it is a utilizing sign of secondary importance to be corroborated with this Hadyor test. Sometimes the Hadyor test evokes geotropic or apogeotropic horizontal nystagmus of equal intensity, and now we need secondary signs. Leftward Hadyor evokes no nystagmus initially. So we were taken aback, but we knew that this often happens in horizontal canal BPPV. So we proceeded to carry out the Hadyor to the right. The Hadyor to the right evoked a very strong geotropic horizontal positional nystagmus that you see right now on your screen. It was non-persistent, lasting less than a minute, but we need to repeat a Hadyor test to the left to evoke a identical geotropic horizontal positional nystagmus. And here you can see that now it evokes a geotropic horizontal positional nystagmus on leftward Hadyor with the quick component beating towards the lowermost left ear. We repeated the Hadyor to the right to confirm the nystagmus which is stronger, and consistently we found that had yaw to the right evoked a stronger geotropic horizontal positional nystagmus. So the lateralization to the long posterior non-ampullary arm with canalolisthesis as the mechanism of the horizontal semicircular canal on right side was confirmed. We carried out a Gufoni maneuver for the right horizontal semicircular canalolisthesis of its long posterior non-ampullary arm, and the Hadyor retest was done the following day. Sit to supine, no nystagmus. Again, this is a standard protocol in our clinic to keep the sit to supine position for at least 30 seconds. The slight beats that you see do not qualify to be nystagmus because there is no accompanying vertigo. Hadyor to the left did not evoke any positional nystagmus. Again, we waited for at least 30 seconds. Waiting 30 seconds in horizontal semicircular canal BPPV during the leftward or rightward Hadyor is appropriate because the horizontal semicircular canal BPPV has usually a shorter latency of 5 or less seconds. That is the nystagmus latency I am talking about. The Hadyor to the right also did not evoke any positional nystagmus. The patient is being followed up daily since we did the repositioning maneuvers, and she continues to be symptom free. A right sided Dix-Hallpike test was also undertaken in case we are missing something. The right Dix-Hallpike test also did not evoke any nystagmus as you see on your screen. So this is how the oculomotor responses generated during the positional test help us know the location of otoconia after a maneuver is undertaken, but it is always pertinent to perform a positional test after you have done some repositioning maneuver. So this is how the positional vertigo is being treated at my center. Thank you very much. I finished my